Hi everyone, I'm Dr. Rafika, and today we are going to learn about orbit and its contents. So it's not going to be a very conventional anatomy lecture. It might be like just a conceptual overview, and I'm going to share some pictures which will help you like relate when you're like going through the subject in your books. So let's begin. So have you ever given this eye rolling? And pretty sure some at some point of time we all would have. Now I want you to see this picture and check if this baby is normal. Is it? No, right? So this right eye is having the eyeball mediated towards the medial aspect. It means this baby is having squint. So now we will see in this lecture like how this was caused and what is the anatomical basis of all these conditions. So first of all, we should know what's a bony orbit, how it is located. So here we can see this is the nose. On either side of the root of the nose, we are going to have a pyramidal shaped cavity, which is made up of many bones, as we can see here. First of all, from above, we have this bone, you know it is frontal bone. And from the sides, we have the zygomatic bone. And medially, we are going to have this maxillary bone, maxilla. And behind this, we have this lacrimal bone, ethmoidal bone, and here we have the sphenoid bone. In sphenoid bone, we have two parts here. One is lesser wing of sphenoid, other is the greater wing of sphenoid. And here we can see two fissures which is called as superior and inferior orbital fissure. And here we have this optic canal. Now, we should know about two axes before we begin. Number one is called as visual axis. Another one is called as orbital axis, right? In this image, you're seeing these orbits from above. So we have, this is the nose and this is the medial wall of the orbit and this is the lateral wall of the orbit. As you can see, the medial walls of the orbits are placed parallel to each other, separated by a distance of 2.5 centimeters. Whereas if you notice, this lateral wall of the orbit, they are diverging at an angle of 90 degrees from each other. And then if you see, the eyeball is located this way and the optic nerve is going to travel in this region. If you see what is an visual axis, the axis which is passing through this anterior pole of the eyeball to the posterior pole of the eyeball is called visual axis. Next, what is an orbital axis? It is the axis which is passing through this optic canal and it is going to cross the floor of the orbit and it is going outwards. That is orbital axis. Now, there is going to be an angle of about 23 degrees between them. And I would say now, here, along this orbital axis only, we are going to have the attachment of the optic nerve. Now you might wonder, like, why is it oriented this way? So, because light rays are going to just enter the eyeball in the anterior pole and it is going to fall on the retina here, right? And optic nerve is attached here. What if the optic nerve was like attached here? Why not? Because when the lights are passing here, light rays are passing here, and if it is going to fall at this point and the optic nerve is attached here, there is a point called as blind spot in the retina that when the optic nerve is attached at this point, that point is going to have a blind spot, meaning there is going to be no rods, no cones in that spot. So if the optic nerve is attached exactly at the posterior end of the visual axis, then we can't see any images, right? That's why very neatly it is placed about 3 to 4 millimeters medial towards that posterior pole of the eyeball. So that's the trick, and that's why there is an angle between this visual axis and the orbital axis. Next, within the orbit, these are the different contents we are going to learn about. There is going to be eyeball, fascia, muscles, vessels, nerves, lacrimal gland, and fat. Here, this is an overview image where you can see, like, this is the right eye. Imagine this is my right eye and we have removed the lateral wall of the orbit and we can see the eyeball, the optic nerve, and the different extraocular muscles running here. But are they going to be this empty? No. They are going to be filled with some fat. This is a superior view where we can see these contents, and in between they are filled up with fat, and there is going to be a lining around this bone and around these muscles. Next, again, this is an anterior view where you can see the eyeball surrounded by some sheath, and then there are few muscles, and then there is some fat, and here we have the lacrimal gland, and again, this is the bony orbit. So this is how it's oriented. Now let's see about the first part of the lecture, that is fascia. This fascia is like very important. Why? Because if the eyeball is just lying like this, like the optic nerve is coming and we have the eyeball here and it's lying within the orbit, it's going to be just hanging within the fat, right? But it can't be like that. It has to be held by someone, covered by someone, protected, and it is going to supported by all the directions, right? So that is the function of this fascia. In fascia, we have two types of fascia. Number one is called as orbital fascia. What is it? Orbital fascia. It's otherwise called as periorbita. It's also called as periorbita. Now, as you can see, this is a line diagram. This is the posterior end, this is the anterior end, eyeball and optic nerve. Can you see this one lining which is lying parallel to this bone? That is our orbital fascia. Basically, do you know what this is? This is the periosteum of the orbital bone. Okay, and this is the periosteum and it's going to be loosely attached, and if you want to separate it, you can easily separate it. And anteriorly, if you see, it is going to continue with the periosteum of the bones of the face, above to the frontal bone, below to the maxillary bone, etc. And posteriorly, if you see, it is going to merge with the sheath of the optic nerve and it is continuing backwards. Now, okay, ma'am, what is the relevance? Like, why should we know there is this periorbita? Can you think? If there is going to be any bony fracture here, right? If there is like bleeding, the blood might get collected in this space. Okay, so you have to observe that. Or if you have to like scoop out the entire contents of the orbit, you should know there is a fascia, which I have to also make sure whether you want to incise it, whether you want to remove it or leave it intact, all those things. So that's why you should know about the orbital fascia or periorbita. So now from this sheath, there are going to be certain extensions into different parts. For example, we are going to have three extensions. Number one is called as orbital septum. What is it? Can you see this orbital fascia? From above and below, there is going to be an extension of this fascia into the upper and lower eyelid. Why do we need that? Again, because eyelid is a very muscular structure, right? It's all made up of just connective tissue. To make a skeleton for the attachment of the eyelid muscles and everything, we have this one extension that is called as orbital septum. Number two, as you can see in this image, from the medial wall here, do you see one muscle? That one is called a superior oblique. It has a very interesting course, like it goes in the front and then takes a sharp turn to go behind to attach. That's for some movement purpose. For that, here it is going to be pulled up by a fascia, by a pulley. That is called as the fascial process for the trochlea of the superior oblique muscle. This again, this pulley is a modification of our periorbita. Last, we have this lacrimal fascia, which is nothing but the fascia covering the lacrimal gland, again protecting the lacrimal gland. So now can we recall? So first we studied about the periorbita and how it is attached. It's nothing but a periosteum of the orbit, and we are having three extensions of this periostea. Number one, orbital septum, then fascial process for trochlea, then we have the lacrimal fascia, right? So this is the first kind of fascia. Next, we have very important fascia. This is called as bulbar fascia, right? So in this image again, if you see, this is the eyeball. Eyeball is going to be covered by a thick sheath. That is called as bulbar fascia. Okay, anteriorly, if you see, it is going to attach to this point. Which point is this? If you remember from your previous classes, this is the cornea, isn't it, of the eyeball. And posteriorly, this is the sclera of the eyeball. This junction between the cornea and the sclera is called as corneoscleral junction or limbus. Okay, so anteriorly, it is inserting at this limbus, and posteriorly it is becoming continuous with the dural covering of the optic nerve. Now again, why is this important? Like sheath, it's you might feel like this is just an introductory part. No. So what happened was, when I was in my MBBS, when I was in my internship, and it was an ophthal posting, and in the evening rounds we had to like put all the notes, and we have to like do some dressing and stuff along with a postgraduate student. So what happened, we had a patient, he came in and he was like talking to the postgraduate, and he was like removing his left eye, and there was no eyeball. They had removed the eyeball for some procedure, like for orbital cellulitis, or it can be a tumor, or it can be because of trauma. So they had removed it. I was like a little bit shocked for a minute, because we have watched only in movies, right? You would have seen like villains having the left eye patch, and they do have the prosthesis for the eyeball, right? So all these procedures, like how are they like putting the prosthesis inside, or how are they like removing the eyeball contents? This is the sheath which is holding the eyeball actually. So if you have the eyeball like this sheath is going around the eyeball and covering it entirely till the cornea. So if at all you want to remove the contents of the eyeball, what will you do? You have to put an incision here and here, all around throughout the circumference, and then you go in and sweep out the contents and then remove the eyeball, isn't it? And then if you want to stitch back these two sheaths, you can stitch it back together, or if you want to put a prosthesis, you can do that. So this bag like structure holding the eyeball is like very important, please know that. And this is also called as Tenon's capsule. This term is very important because in ophthalmology clinical side they don't call this commonly as bulbar fascia but as Tenon's fascia. So what is this? This is a thin loose membranous sheath around the eyes. It is going to extend from before to in the front, we know, and there is going to be a small space above it that is called as episcleral space. Okay, why am I again saying this? So nowadays there is again this space is being used for injection of anesthesia. So you should know like okay, should I put the needle here, or if I should put the needle here, or if I should start the approach here, isn't it? So this is the reason. Then just like the extensions we had in the periorbital fascia, we have some extensions from the bulbar fascia. So as we know, this is the eyeball, this is the fascia covering, that is Hamara, Tenon's capsule, and above, below, and in the sides we have the muscles going. So I told you somebody should hold the muscles to the bone, right? So this sheath is giving out an extension in all the sides covering these muscles. They are called as medially, which is covering this medial rectus muscle and which is going to extend towards medially and insert into the lacrimal bone, that is called as medial check ligament. Whereas laterally, if you see, this is the lateral rectus, again it is extending outwards to attach with the zygomatic bone, that is lateral check ligament. Number 3, this is the most interesting part. See, below we have a lot of gravity, right? So to prevent the orbit from like displacing or even a little bit, we have a nice sling-like structure that is called as suspensory ligament of eye. It's also called as Lockwood's ligament. What is it? Lockwood's ligament. As you can see, this ligament is widened at the center and it is going to be narrow at the sides, and it is helping in the suspension of this eyeball. And we have 2 muscles enclosed by this suspensory ligament of the eye, and above also we have the sheath covering the superior rectus and the levator palpebrae superioris, right? So far we saw the introduction, we saw what are the 2 types of fascia. One was periorbita, other was the bulbar fascia, otherwise called as Tenon's capsule, right? Next, we are moving on to the muscles now. In the muscles, you have to divide it into 2 parts. One is involuntary types of muscles, other is the voluntary type of muscles. In involuntary muscles, you have to know there are going to be like 3 muscles. One is called a superior tarsus, inferior tarsus, and orbitalis muscle. I'll show you a good image. You can see this is a cut section of the eyeball and the eyelids here. Here above on the top, we see one muscle going into the upper eyelid. That is called as levator palpebrae superioris. Okay. So to recall the name, you should remember it like levator means elevation of the upper eyelid. So it's going into the upper eyelid. So levator palpebrae, it's going into the palpebral part, like close to the palpebral part of the conjunctiva. Palpebral superioris, it's going from above. So it's called a superioris. So this levator palpebrae superioris muscle is going into the upper eyelid. If you can see a small muscle, that is a few fibers from this levator palpebrae superioris will go and insert into the superior tarsal plate or upper tarsal plate. So that muscle is called as superior tarsal muscle, and it's going to help in the elevation or depression of the eyelid. When it is going to contract, it's going to pull the eyelid above, so it's going to cause elevation of the eyelid. It is also called as Muller's muscle. Just remember that, because sometimes they simply say it as Muller's muscle. And below, if you see here in the floor of the orbit, we have some muscles which is called as superior oblique and inferior oblique and inferior rectus. From there, we have a few fibers going into this inferior tarsal plate. That again is called as inferior tarsal muscle. It's called as inferior tarsal muscle. Now you tell me, if it is going to contract, it will cause elevation of the lower eyelid or depression of the lower eyelid? Depression of the lower eyelid. Okay. Next, we have the orbitalis muscle lining in the floor of the orbit, which is not that much explored yet. Next, we have these important voluntary muscles. Like this is the one causing all the movements. They are like one of my favorite muscles to study, right? So here we have 4 recti muscles. Okay, 4 recti muscles. I have a small ball here. As you can see, consider this as like the right eyeball. Here we have the superior, inferior, medial and lateral aspect. This is the pupil, right? Now, there are going to be 4 recti, I told you: superior rectus, inferior rectus, medial rectus and lateral rectus. And then we have some oblique muscles, which is superior and inferior oblique. We'll see that in a minute. Then we have the levator palpebrae superioris. Now, in this image, as you can see, that's the anterior aspect. This is the posterior aspect. Here we have a ring, and these are the 4 muscles: superior rectus, inferior rectus. This is the lateral aspect. So, this is lateral rectus, this is medial rectus. Apart from this, I told you there are 2 oblique muscles, right? So, here on the top, here we have this muscle, which is like taking a curve. That is a superior oblique. And from below, we have this muscle called as inferior oblique. Then above the superior oblique, we have one most important person, that is our levator palpebrae superioris going into the upper eyelids, right? So these are the 6 to 7 muscle names. Yes. So now let's see the common origin and common insertion. It's very, very easy. Now guys, again, we are going in for the orbit. Can you see this one is, can you name this? That is superior orbital fissure. Can you name this one? Yeah, it's written here. Inferior orbital fissure, right? So here in this region, there is going to be a common annular tendinous ring. This is actually, annular means circular shaped. That's a tendinous ring, okay? From there, there are going to be 4 muscles originating. That is, all the 4 recti are originating within this ring. That is also called as ring of Zen. It's also called as ring of Zen. Above, it's going to have the superior rectus, inferior rectus, medial rectus and lateral rectus enclosed within the sheath and taking an origin. And this ring is again going to divide the superior oblique fissure into 3 parts, like the upper part, middle part and the lower part, which we'll see later. Next, do you see these 2 guys? Medially, we have the origin here. So, this is again a zoomed in picture. Medially, we have the origin of the superior oblique muscle, and above the superior rectus, we have the origin of the superior rectus muscle. Both are originating from the lesser wing of sphenoid. Here we had the origin of lesser wing of sphenoid bone. So, that's where they are originating. Now, are you wondering like, okay, all the muscles are done. Are they? We saw all the 4 recti muscles, then we saw 1 oblique muscle, and we saw the origin of levator palpebrae superioris. Where does inferior oblique come from? Here, if you see, this is the maxilla bone, as we know. Do you see this muscle, like starting from anterior aspect and going behind? That is the inferior oblique muscle. That's going to arise from this maxilla, this orbital surface of maxilla, lateral to the lacrimal groove. There will be a small groove in the floor of the orbit. From there, it is originating. So, this is the origin of all the extraocular muscles. Now, where is it going to insert? They are all going to go in the front, and they are all going to go and insert into the eyeball in the sclera after piercing the fascia. Can you name it again? What was the fascia's name? Tenon's capsule or bulbar fascia. Okay. So if you see 1, 2, 3, 4 recti muscles are inserting into the sclera at certain distance from this limbus or sclerocorneal junction. And if you draw an equator here, it's all inserted anterior to the equator to cause more precise movements. And then we have two oblique muscles. So here is a superior oblique and it is going below. They are traveling below the levator palpebrae superioris, going to the medial wall of the orbit, and then it is taking a turn which is held by a trochlear pulley, and then it's going to go below this superior rectus muscle and it is inserting behind the equator. And here inferior oblique is going to go undersurface of the to the undersurface of the eyeball, and again it's inserting below this below this lateral rectus muscle. Now if you see, all the recti were inserting in front of the equator, but these oblique muscles are inserting behind the equator. Okay, so this is regarding the origin and insertion of all these muscles. And what is the nerve supply? So nerve supply, for that we have a small mnemonic. It's very common. It's called as LR6 SO4 and the remaining muscles by 3. That is, lateral rectus is supplied by 6th nerve, that is abducent nerve. Superior oblique is supplied by 4th nerve, that is trochlear nerve. All the rest of the muscles, they are going to be supplied by oculomotor nerve. Okay, so again the mnemonic is LR6 SO4 and the rest by 3. Okay, so this is the nerve supply. Now moving on to the most important point, that is the action of these muscles. Now it's going to occur in 3 axes. Okay, one is going to be the transverse axis. Imagine if I put this into this eyeball, that is the transverse axis. If there is going to be a movement along this axis, what will be the movement? The eyeball is going to rotate like this, isn't it? That is called as elevation and depression. Okay, so that is the elevation and depression movement. Then if I put the axis like this, the eyeball is going to rotate like this. So this movement is called as medial rotation and lateral rotation. The medial rotation can also be called as adduction. Lateral rotation is also called as abduction. Okay, now the end is anterior-posterior axis. So if we put an axis towards the pupil, crossing through the pupil, the movement is going to be like this, rotatory movement inwards and outwards. See, for this the landmark that you should take is the 12 o'clock position of the pupil. If you draw a line, if that line is moving towards the inside or if it is moving towards the outside. If it is moving towards the inside, that is called as intorsion, or if it is moving towards the outside, that is called as extorsion. Now I have a question for you. Like, we have an eyeball. Have you ever intorted or extorted? Can you like really do that with your eyeball voluntarily? No, right? Then how does this movement happen? But when you bend your face, but still your eyeball is like adjusting to the vision, that is when the eyeball is going to rotate a little bit with the muscles. Okay, so if I am moving my head towards this side, it means like this is the pupil, I am moving the head towards this side, so my eyeball would have little bit extorted, right, towards the outside. So that's how intorsion extorsion movement happens, right? The extraocular movements are like very complex. In different positions we can learn, but for now we'll restrict to only the neutral position. Neutral position means your eye is looking at the center towards the front, and your skull is in Frankfurt's plane, like in the anatomical position of the skull. That is called as neutral position. Okay, so for easy memorization, I'm showing you this picture. This is for the right eye, and as you can see, these are the different movements that we have drawn. If we have drawn above, that is called as elevation. Drawn below means depression. inside, means this is the medial aspect, right? Like imagine my right eye, and this is the medial aspect towards the nose. So this movement is called as medial rotation, and that movement will be lateral rotation. And this movement, like if it is eyeball is like rotating outwards, that will be the extorsion. If it is rotating inwards, that will be the intorsion. So these are the different movements. If you want to like simply just go with it and finish it off during your exams time, if you don't have much time, you can just learn this picture and draw it. But let's understand how it is causing these movements, right? Here we can see this person is having the eyeball in neutral position, and this is the movements associated with right eye, right? Now you are going to try and tell me if the patient is moving their eyes towards that side. Now you just don't see this left eye, we just focus on the right eye. Now you tell me if the eyeball is moving towards the right side, that is towards the outwards. Okay, yeah, so here if the eyeball is moving towards the outwards, that is lateral rotation. If it is happening, which muscle should have pulled it? Here we have the lateral rectus, superior rectus, medial and inferior rectus. So if the lateral rectus is contracting, will it pull the eyeball outwards? There will be lateral rotation. So for the right eye, the lateral rectus have contracted, causing this movement. Okay, so outwards, if you see that lateral rotation is caused by the lateral rectus. At the same time, if you see the other eye, है ना? So right eye we have the lateral rectus moving, but at the same time we are going to have a conjugate movement. Then in the left eye, medial rectus should have contracted, right? So for this movement, for this conjugate movement means like both eye moving in the same direction. Now in the left eye, if it is moving towards the right, it means medial rectus would have contracted. You understand? So for this movement to occur, we would have had right lateral rectus and the left medial rectus movement occurring. Next, can you try and tell me like which muscles would have caused this movement? Like if I have to look at the left side, my left eye's lateral rectus should have contracted and the right eye's medial rectus should have contracted, isn't it? So now the medial rectus would have contracted and the left eye ka lateral rectus should have contracted. Next, this, if you see this image, right, you have this superior rectus and inferior oblique causing these different movements. That is, superior rectus is causing elevation, medial rotation and intorsion, whereas inferior oblique is causing elevation, lateral rotation and extorsion. But both of them are causing what? Elevation. So if you want to roll your eyes upwards, right? So which movement is going to happen? Elevation. So for the right eye, which muscles are going to act? Superior rectus and inferior oblique. For the left eye also, both the muscles have to act to take both the eyes together upwards. So here we have both eyes, superior rectus and inferior oblique acting. Same way, if it is going to move downwards, at the same time, then it is caused by superior oblique and inferior rectus of both the eyes. So can you just recall a little bit? If you have to move your eyeball towards the right, if you want to cause this lateral rotation, if you want to see on the right side, right eyes lateral rectus, left eyes medial rectus was contracting. If I have to see this way, my right eyes medial rectus should contract and left eyes lateral rectus will contract. Now if I want to like see above, there is going to be contraction of two muscles in both the eyes. Number one, superior rectus. Superior, say if it is coming superiorly, it's going to pull. That's default. Another muscle is inferior oblique muscle. And if you want to look downwards simultaneously, now we are going to have the inferior rectus and the superior oblique of both the eyes acting together. Now, this is a little bit of a tricky movement. So if you have a patient with squint or if you want to check the eye movements of different in a neutral position, till now it would have been like very easy. But for this movement, we have to apply a little bit of logic. See, if you split this eyeball again and compare it with the right eye, the movement is happening in this right upper quadrant, right? And compare the same thing with this image. The movement is happening in this right upper quadrant, in this angle, meaning this axis also, and along this axis also there have to be movement. That's how this 45-degree movement will happen. So, in the right eye, which muscle is causing this movement? The answer will be inferior oblique, right side inferior oblique, isn't it? Yeah, just understand this much for now. Next, if this movement has to happen, we are just talking about the right eye. If this movement has to happen, like again we have split it into 4 quadrants, and the movement is happening in this quadrant, that is upper inner quadrant here. So as you can see, which muscle is causing movement in this direction? That's our superior rectus, isn't it? So whenever you are like checking for a patient, imagine I'm the patient and you're just checking my right eye. If you want to check if the inferior oblique is functioning properly, so how will you ask me to move my eyes? You will ask me to move my eyes to the right upper quadrant. You want me to see on the right upper quadrant, okay? Now, if you want to check my right eyes, inner this muscle, that is our superior rectus muscle, how will you check that? You will tell me to rotate my eyes towards the upper medial quadrant, inner quadrant, isn't it? I have to see like this. So this picture you should have very clearly in your mind. Now we'll go for a little bit of, we'll step it up a little bit. Yeah. So for one eye we saw. How about if it is a conjugate movement again, like both the eyes have to move. See, this is for the right eye, right? This picture is for the right eye. If I have to assess for the left eye, what I'll do is, this mirror image is what we are going to take. Because if it is going to be like this, the mirror image of the right eye is going to be for the left eye, isn't it? That's how it is oriented. So now, if I have this picture here for the right eye, and I'm going to take a mirror image of the picture, now in this medial aspect, in this quadrant, can you tell me which muscle will be acting? That's going to be superior rectus. So what will happen? So in this side I have the superior rectus acting, and this side will be the inferior rectus acting. So if there is going to be conjugate movements towards the right upper quadrant, then the muscle responsible will be right side's inferior oblique and left side's superior rectus, because of the mirror image. Same way, if we go for the next, this movement, this is for the right eye, and we are looking at the upper inner quadrant. So here again imagine a mirror image here. So if this is where the movement is happening in the mirror image, and there should be a movement in this region which will be contributed by the inferior oblique. So right side superior rectus will be helping, whereas in the left side it will be inferior oblique. So this is how the different muscles are acting, and this is how this left upper quadrant movement will happen. Now can you tell me like which muscles are going to help here? Just think for the right side and then you can correlate for the left side. Yeah, here we are going to have the right superior rectus, and in the left side it's going to be by the left inferior oblique muscle. Okay, now again same way, if the movement is going to be in this lower quadrant and towards the outside, now you know it should be superior oblique. And now tell me, in the left eye which muscle will be acting? The mirror image muscle, that will be this guy. Okay, so left side's inferior rectus will be acting. Now if you are checking to this quadrant, like lower inner quadrant, right side inferior rectus, whereas left side superior oblique. So what you can do in a simpler way is like just remember for one eye and then you can correlate for the other eye. Okay, So before we go for the applied, now I want to you to again revise the nerve supply of these muscles. We studied that it is going to be LR6, that is lateral rectus 6. Okay. Now imagine here we have this muscle, eyeball. Sorry, yeah, LR6. This is the lateral rectus muscle. Okay. And I'm telling you, lateral rectus is supplied by sixth nerve, abducens nerve. Okay. So if it is contracting, it was supposed to cause this lateral rotation. है ना? Now, if it is paralyzed, if this lateral rectus is paralyzed, that is abducens nerve, sixth nerve is paralyzed, what will happen? The eye cannot move this way. Okay. So there is going to be no lateral rotation. Then what will happen? There is going to be a deviation towards the medial aspect. So it will mediate towards the nose. So will that be a squint? Yeah, right? That will cause a convergent squint. Convergent means if the eyes are like moving towards the nose, towards the nasal aspect, that is called as convergent squint. Whereas if the eyeballs are like moving outwards, that's called as divergent squint, right? Now, so if there is going to be sixth nerve paralysis and the lateral rectus muscle is affected, there is going to be a deviation of the eyeball towards the nasal aspect. There is going to be a convergent squint. Okay, the patient cannot do lateral rotation. So this one. Next, I want you to again recall the SO4 movement, that is superior oblique trochlear muscle. Now you tell me, superior obliques movement was this, right? So it's going to have the movement towards this right lower quadrant, isn't it? So if that muscle is paralyzed, what will happen? The patient will not be able to see like towards your right and below. Okay, so if you want to just directly check superior oblique muscle, you ask the patient to see the right lower quadrant, isn't it? So next, how about the last one, that is oculomotor nerve? The rest of all the muscles are supplied by oculomotor nerve, isn't it? So for example, we have the superior rectus, that inferior oblique, medial rectus, and inferior rectus. All these muscles are supplied by oculomotor nerve. Now you tell me, if a patient is going to have paralysis of oculomotor nerve, meaning 1, 2, 3, 4, all these muscles are not going to work. The only muscles that are working is superior oblique and the lateral rectus. So what will happen? The eyeball in a resting position, it will stay deviated towards this right lower quadrant. You know why? Whenever if some muscles are paralyzed, the muscles which are working will work more to compensate. So they will pull hard. Superior oblique will be pulling hard, causing the deviation of the eye to the right lower quadrant. Okay, so if you want to if you are checking a patient and they're having the eyeball deviated to the right lower quadrant, what will you think of? Oculomotor nerve palsy, right? So that's your clue. Always look for that. And yes, as we saw, there can be squint. It can be congenital or it can be paralytic squint, or there can be nystagmus. Usually squint happens as a congenital condition, as we saw in the first picture of the baby. And in that case, it's not usually because of nerve paralysis. It's usually because of, let's say, short muscle length. Medial rectus muscle might be shorter. So for that reason, they can have the squint. It can be convergent or divergent, as I told you already. I want you to take a look at this picture and tell me what's the patient having? What's the problem here? So we know there is an abnormality in the left eye, right? And the eyeball is deviated toward outside, meaning the lateral rectus is working, isn't it? Medial rectus is not working. Okay, so lateral rectus, if it is working, it means LR6, that is abducens nerve, is intact. Okay, lateral rotation is happening. There is a divergent squint here on the left side. Next, yeah, let's go for some clinical questions. Please go through this. A patient cannot abduct the right eye. Which muscle is affected? Abduction means I told you lateral rotation, that is moving the eye outwards, right? So if this movement is not happening, then which muscle is responsible? This guy, lateral rectus. Abduction is not happening. So the answer for this will be lateral rectus. Then a patient is unable to look upwards after orbital floor fracture. Okay, so here which muscle must be entrapped? So here the answer is not given. Okay, I'll tell you. You guys can think, don't look at the options. Can you think there is going to be an orbital floor fracture? Which muscle was originating from the floor of the orbit, from in the front, not from the ring of Zen, not from the tendinous ring? Inferior oblique, isn't it? So, there is going to be a fracture in the floor of the eye. Which muscle might get entrapped? Inferior oblique. Okay, so remember always that. Next, we have a patient having vertical diplopia that worsens while walking downstairs. He tilts his head to the opposite side to compensate. Which muscle is paralyzed? So here I want you to in a simpler way, think that the patient is going downwards, okay, and the patient has to look down. From the image, can you recall like which muscles were responsible for like the depression of both the eyes at the same time? So for the right eye, we had inferior rectus and superior oblique, right? So both eyes, inferior rectus and superior oblique, they will be responsible. So we have the inferior oblique option. That might be the answer. That is the answer. So when they are like when there is like a nervous coordination, what will happen is especially during movements, like the patient is like climbing up the stairs or going down or going in the train, that's when it triggered in the central nervous system involving all the vestibular nerve and stuff. Then it leads to nystagmus. We'll move on to that in later part of the lectures. Yeah, so this is what is all about today's lecture. One takeaway message, if you have to remember, is Tinon's capsule. Okay, and then you have to always remember about that eye movements. They are checked in the neutral position. If the patient is like adducted or abducted, and then you're checking, those movements are not covered here. So when you're having a normal patient and when you're checking when you're checking in a neutral position, you can correlate all these movements with the muscles. So nerve supply, LR6, SO4, rest of the muscles 3. If there is going to be a oculomotor nerve palsy, the eyeball is going to be deviated to the lower right quadrant. Okay, so this is all about today's lecture. I hope you understood, and if you have any doubts, you can ask me in the comment section. Thank you so much.